So I'll start by just quickly overviewing dementia and then focusing on issues for pastors and people in the church. So next slide, please. So what are we talking about? So dementia then is a clinical syndrome, and we discussed diagnosis last time. In this case, then you need evidence then of multiple impairments in what's called cognition, that is aspects of mental functioning, so how you learn things and remember things, how you see and perceive the world around, how you hear, how you process language, how you deal with shapes, how you plan and reason, all aspects of mental function that's to do then with learning and applying ourselves in the world. You've got objective evidence of this. In other words, it's not just a memory problem. Memory failure is prominent in dementia, especially in Alzheimer's disease, which is the commonest cause of dementia, but it's much more than memory problems. There's all sorts of other dysfunction that happens, and that it's important to bear in mind, because one of the things that you can do is you speak into somebody with dementia and you say something to them and you think they're not paying attention. Now, they may not be paying attention because concentration can be impaired. You think they're not paying attention, they're kind of ignoring you, being rude because of the way they respond, but it's actually because they can't process the language. They can't actually understand what you're saying. So it's not necessarily, that they're being rude. They might be being rude, they might just poor concentration, but there's these other aspects, and that's one of the difficulties when you are engaging with somebody with dementia. There's multiple things that go wrong that lead to multiple problems with the way that you relate to other people when you're the person with dementia. And then this development of these cognitive problems, the memory loss, the problems with language and seeing things and space and everything, all that then is a change. So people who can be born with a degree of brain damage, and we used to call them mentally handicapped people, or then they were called learning disability, and it's one of these PC terms that keeps changing. But you can have that from when you're young, and that's the same sort of problems. But dementia occurs in people who did have healthy brain function into their adult lives, and then that brain function gets damaged for some reason and they decline. And that decline then leads to an inability then to function normally in the world, that gets very profound, severe. And we would say it's not explained by delirium. So they're not acutely ill with an infection or some other illness that's affecting brain function, but when that other illness is treated, it goes away. It's not that. That's very common, especially in hospitals. It's not that. It is something that's there long term. It's a chronic condition. Next slide, please. So as you'll know, it's extremely common. We give lots and lots of figures. So, it's hugely common. 850,000 is the usual figure given at the moment in the UK. It's going up and up as the population ages. And sometime in the next few years, it'll reach 1 million plus. It costs huge amounts of money. You get figures like in the UK, it's like the size of the Turkish economy. It's a huge amount of money that it costs to look after people. So, for example, it costs more than heart disease and cancer put together. That's the kind of burden of dementia in this country. It's very common. 1 in 14 is a kind of standard figure at the moment for people over 65. It goes up. It's about 1 in 3 by the time you get to people over 80. And actually the same number, because of increasing longevity, but unless we get treatments for dementia that modify the diseases, 1 in 3 born today will get dementia at some point. So that's not a thing that you would tell people who've just had a newborn baby. But, it's how common the condition is. Next slide, please. Now, dementia is very commonly assumed to be the same thing as Alzheimer's disease. So people often use them interchangeably. Say he's got Alzheimer's or he's got dementia. They're not the same. Dementia is what I've just said, and it's due to different diseases. Now, Alzheimer's is the commonest cause. Most people who have dementia have Alzheimer's, but lots of people with dementia have it for other diseases. Next slide. So there's all these other causes. Now this is I run a national network of brain banks. That is where people who've died have donated their brain tissue. It's been looked at under the microscope, and the cause has been worked out of why they had dementia. And this is something that's just published about now. It's just being published. So about half the causes are Alzheimer's disease in this study, which is lower than is usually said. But that's because Alzheimer's contributes to a lot of other diseases where there's other pathologies, other diseases going on. So lots of people have more than one disease in the brain causing their dementia. So Lewy body dementia is the second commonest cause. It's not usually recognized as such. Vascular disease is generally said to be very common. It's not as common now as Lewy body disease. That's for different reasons I won't go into. Mixed causes are very common. The point here is simply that dementia isn't the same as Alzheimer's. There are different diseases, and these different diseases do have different patterns and have different treatments for some of them then that we use. Next slide, please. So diagnosis. So lots of people with dementia aren't diagnosed still, though that has improved a lot in the last 10 or 20 years. But somebody needs to raise the problem. You know, somebody's getting old, they're struggling a bit with remembering things. And nowadays there's more of an awareness, well, are they developing dementia? But still, you know, somebody needs to bring that to medical attention. Somebody needs in the family, or the patient needs to say to the GP, I think this person got memory problems, they may be getting dementia, and they need then an assessment in primary care. They then get referred to people like myself in secondary care who do a medical assessment. We might do some brain scans and so on, and we then say, yes, you know, she has got a dementia and it's due to, looks like it's due to Alzheimer's disease, or it's due to Lewy body disease, whatever we think it is after our assessment. So somebody needs to raise the problem, comes to medical attention, gets diagnosed. Next slide, please. Now, dementia is defined and diagnosed, as I said, in terms of what we call cognitive problems, problems with memory and learning and use of language and seeing shapes and thinking. But the worst problems for people with dementia, and the worst problems then for their families, are not actually the memory problems and these other things. They can be difficult, but the major problems are the other aspects of the physical impact and especially the disturbance in behavior that occurs with dementia. These are the things that really stress patients and their families. Next slide. So dementia can cause any kind of psychiatric symptom. So one of the things I used to like asking students was, what's the commonest cause of, you know, hallucinations? And they would usually say schizophrenia, and it ain't, because dementia is a more common cause, and probably delirium is as well, actually, in hospitals. So, but hallucinations are common in people with dementia. Delusions are common in people believing false things, or I should say, hallucinations means, visual hallucinations means seeing things that aren't there. Auditory, hearing hallucinations means hearing things that aren't actually out there and happening. Okay, this is psychosis. It's having experiences that feel like they're in the world out there, but they're not actually real in the world out there. And we'll obviously think on this more when we look at psychosis in the future. But psychosis, depression, anxiety, any kind of obsessions, any kind of symptom that you can think of in any mental illness occurs in people with dementia. Some are much more common, so apathy, for example, is extremely common in people with dementia and very frustrating. So somebody is apathetic means they've lost their drive to do anything, and so they will just sit and do nothing, very, very little. And this is because of the impact of the dementia, the diseases that cause dementia, on the part of the brain that normally gives us our drive to get up and do things. So we kind of take it for granted that something's interesting, we get up and do. But that depends on parts of our brain functioning normally that underpin that drive. And that drive is just damaged in people with dementia, so they don't have it. So they just sit there and don't do anything, and it's extremely annoying for carers. So I often say, look, it's not his fault. He's not being difficult. He's not being lazy. He's not ignoring what you're saying. He's ill, and he's lost the drive. So you've got to try and encourage him and externally try and provide some of that drive that he doesn't any longer have himself. Don't get annoyed. Try and encourage him to do things. But apathy is a big problem, as are these other things. So shadowing is where somebody, typically with more severe dementia, will follow the person, somebody else around. So if the husband has dementia, he just follows his wife around the house all the time, which is extremely annoying, okay? And people get, and it can lead to aggression. It can lead to aggression because it's so annoying. That's why it's called shadowing, because they're just always there. They're just kind of stuck onto you. And it's very difficult. Wandering behaviours, again, very common in people with more advanced dementia. So on the one hand, yes, apathy can be very common, but then you get people who just won't stop moving. They just move constantly round. So in modern hospitals, in modern hospital wards, and if you look on nursing homes, you try and design them so that people can move continuously round on a circuit on the ward. Because when these people with drive, so instead of with apathy, you've got no drive, or very little drive, you don't do anything. With this, you've got a lot of drive, and you need to keep going. So if you walk down a corridor and you hit a door, you get very annoyed because you want to keep going. Now, you and I would think, I've hit a door, I need to turn around if I can't get out this door and walk the other way. But they don't do that. They just get annoyed that they can't get through the door because their mental function isn't very good, and they're driven to keep moving, and so they get agitated as a result of this wandering that's obstructed. So on wards you build them so that they don't get obstructed. And then sleep disturbance is very problem. So my point here is that there are a whole series of very difficult behaviours that people develop with their dementia, and that aren't what you use for diagnosis. We think of dementia in terms of memory problems, and yes, forgetting things can be annoying, etc., and is a problem, but these are the worst things. These are what really causes difficulties in families and people who are caring for people with dementia. Next slide, please. So some of these problems are quite severe, okay? So if you've met people with dementia, you try to help them. They become aggressive, they will be rude, they will swear at you. Sometimes they will harm themselves. Sometimes it's difficult to understand why they're doing this. Punch doors, headbutt walls. It's an expression probably of the internal distress and frustration. But obviously it harms themselves, and they harm other people when they get aggressive. They hit out, punch, bite, scratch people around them. Next slide. And then there's the sort of, if you like, the basic physical health burden of trying to care for somebody with dementia when bodily functions begin to fail. So, when you're healthy, you take it for granted that you can, eat your food, you can take your drink. When you've got dementia, you can't do those things. You need help with eating and drinking. You take it for granted that you will put on the right clothing and clean yourself up in the morning. People with dementia don't do that. They don't change their clothing at all, and therefore can become dirty and smelly. Or when you want to try and change their clothing, it can be difficult to persuade them to do that, and that can lead to confrontations and aggression. Again, we take it for granted that we know when we need to go to the toilet. People with dementia lose an awareness of that, and simply therefore, as it were, go to the toilet where they are, rather than actually on the toilet. And these sort of problems with people with more severe dementia occur all the time. Okay, once you get to this stage, they don't go away. You don't get somebody who once was incontinent and now they've kind of improved and it's gone away. It's not treatable in that sense. Okay, so the burden, the physical burden of caring for somebody who needs this level of input 24 hours a day is very hard on people who are living with them and looking after them. Next slide. Okay, so how do we help? Try and help, just very briefly from the medical side. There are now a couple of classes of treatments that we use for people with dementia, that is specific treatments for the causes of dementia. They're of modest but significant help. There is as yet no new treatment since about 20 years ago. And we hear from time to time in the media about some new treatment that's going to be allegedly a cure for Alzheimer's. There isn't anything in the offing. Even the aducanumab, which is being put forward at the moment in America for licensing, is really a very modest, if real, effect at all. So for the time being, we haven't really got treatments that will cure or even stop the progress of dementia. We've got some treatments that help people a bit with their memory and their hallucinations and so on. A lot of the treatments we give are therefore focused on those symptoms to try and treat the depression or the anxiety or the agitation, not the dementia itself, the disease, and not the memory and the concentration, but other aspects. And this is important to treat these things because these are horrible experiences for the patient and horrible for the family looking after them. So once we've made a diagnosis and we look to use these sorts of treatments in collaboration with people in primary care, people then need support. Usually now we'll diagnose people relatively early. It's in my time as a consultant, we've moved to diagnosis 2 or 3 years, maybe 4 years earlier than we did. So people are much earlier in their dementia than they were. And so it's at a stage where you can help somebody think about their future with dementia while they're still able to some extent to think and plan about that. So, you want to get fundamental things about, what's called care planning. So sorting out, making sure they've got a will that they're happy with, lasting powers of attorney, that they think about who they want to care for them, where they want to be looked after, and so on. So you want these things sorted out, and obviously provision of information for the patient, for the family, so they understand something of what it means, this disease that they've got, and this dementia syndrome that they've got as a result. So these are sorts of things we do in the health service. Next slide, please. So as well as those things, then also there is, the need for psychological support. This is earlier on, you want to help the person come to terms with the diagnosis, to understand what it means, to support them with some of these problems, depression, low mood, anxiety, and so on. Carer assessment should be part of what happens with a dementia assessment. That is for the immediate family largely, to support the family, those who are providing the care. Care in a lot of people is provided not by family members, because a lot of older people live on their own, and therefore they have carers who are paid to do that work from outside the family, and that's important and good. And they may get help at day centres, though these are all being closed nowadays, and they're not open at the moment anyway because of COVID. And then there's sort of respite care, so when people get more severe with their dementia, you can put people support for periods of time away from home to give a period of rest and recuperation for the family, and some rest for the patient away from what can be a difficult home situation. Next slide, please. As you'll be aware, a lot of people, but not everybody with dementia, goes into nursing homes. There are different levels of nursing care. One of the gratifying experiences for me in my time as a consultant is seeing the nursing homes improve in quality, seeing an awareness of dementia become, pretty standard among carers in nursing homes. There's a lot of work that, was done 15, 20 years ago to teach people in care homes about dementia. I used to go in and they would say to me, we just tell her, go and eat her food, and she just doesn't listen to us. And they had no awareness that this was because the person had dementia, and that she either couldn't understand the language that was being used or simply couldn't remember afterwards what they were asked to do. But that led to kind of bad relations with the carers, because they blamed this person for ignoring them, because they simply didn't understand about dementia. Now, I don't have that now, I'm glad to say. They understand these are sort of fundamental. The person's not being difficult, awkward, or rude to them. It's their dementia. And it's why it's important for dementia diagnosis to be made so that the carers can then understand and respond appropriately. Now, if you have a person with dementia in your family and you've then been working to support them and provide all this care that can be extremely difficult as the health burden increases, the physical burden, the difficulty in managing their apathy, their agitation, whatever it is, then it may be necessary for your loved one to go into a care home. And a lot of people, and I suspect especially Christian people, think that if that happens, you've kind of failed. Okay, you say, I should have been able to manage him. I told my husband, till death us do part, I will always be there for him. And he said to me, I never want to go into a care home. And I said, I won't let you go into a care home. Okay? This is what happens. But it simply isn't possible to manage people at home sometimes on your own. Obviously, in past societies, there was a wider network. But in our society, with kind of our isolated, smaller family units, one or two people can't manage a lot of people with dementia because of the burden of the illness that they have. So the fact that somebody goes into a nursing home does not mean that the people looking after them at home have failed. It's something that simply can't be avoided a lot of the time. And within nursing homes, there are different levels of nursing care and other care that can be provided, which I won't deal with. But, you don't, from being on your own or being with a family member or with your family, it's not just to what you might think of as a nursing home. There are other lower levels of residential care that can be provided. Okay, next slide, please. So trying to move then to issues for pastors in particular and people in the church. Next slide, please. So again, as with depression, I said, as with other mental illnesses, do encourage people to come to church, do encourage them to engage. They might be apathetic, they might be low in their mood, they might not want to come, they might, as I say, because they're apathy, not the drive to do it. That's not because they're sinning or being bad, it's because they're ill and they've lost the drive to do this, and they need encouragement and support to get there. And of course, when they're there, you need to think about again where they're going to sit in the congregation. Generally not a good thing to put them near the front of the building or in some kind of prominent position, because they might become distracted or distressed. And therefore you would want somebody in a position where, if that happens, they can easily be supported without it disturbing the rest of the congregation, and perhaps taken for help outside the worship area. So thoughtful positioning, and clearly you want people with the person with dementia whom they know. They struggle to remember who's who, but at least maximize the chance that person will be able to support them because it's somebody they recognize and know and associate with the church and so on. Familiarity. So, one of my irritations with sort of changes in worship and how people do worship is it's actually very cruel to people with dementia, because we get used to, we're people who do well with habits, we get used to activities that are predictable. We come to a service, we expect it to be in a certain way, a certain order. And if that's changed around, that's very distressing actually to the person with dementia. They're used to singing this hymn, and now somebody's gone and changed the tune. They're used to singing this hymn, and somebody's gone and fiddled with the words. And that's annoying, it's distressing to people with dementia. Now, this isn't an argument for certain styles of worship, but it's just saying that you've got to think about what you're doing, think about people beyond your own group, think about the impact on other people, including people with dementia, when you go changing things around, because people with dementia struggle with change because of the impact of the dementia. And so, you might need to tactfully help somebody in the church, to support them in following the hymn, changing the pages, following the reading, open the Bible for them. They might not be able to read it, but nonetheless, there's an assurance of having the open Bible because that's what they're used to, and so on. So it depends very much on the individual and you knowing them and supporting them. Next slide, please. So the causes of dementia are causes which lead to death. Dementia is a terminal illness, or it's due to a series of terminal illnesses, if you prefer that, the different dementias. And so when somebody gets dementia, they are dying. Now, I know we're all dying one level, but, they've only got a few years to live, okay? So you become aware of that, and you've got to adapt to that if you're living with a person with dementia, and the person with dementia has to adapt to that themselves. They've got a terminal illness. And it's important always to think of dementia as a terminal illness, okay? It used to be very rare when I was in medical school. You might have had the same, Chris. It was rarely put on death certificates that Alzheimer's is a terminal illness. Lewy body disease is a terminal illness. They kill people. And people change, okay? The impact of the dementia on the behavior means it's difficult to relate to them as you once did. At one level, this is the same person. This is the husband you married or the wife you married. And yet at one level, you're aware that they're not the same. You find that they can't remember those things you used to do together. They can't share with you in those happy memories from the past. And that's difficult. They're losing that. So it's not, as it were, just that they've got a terminal illness, which they have, but it is that the terminal illness directly changes the person and necessarily their relationship with you. Because as we said earlier in the previous talk, we are made in the image of God. We're made to be in relationships. When I'm damaged, that affects my relationship with the people who know me. Next slide. So grief is something that goes along with dementia because it's a terminal illness. So one thing this means is that by the time the person dies with dementia, a wife or husband left behind might actually not feel much grief at the end, because they've had years of being with a person as they've died. And so they're coming to terms with that along the way. But it also means that the grief might be worst, most impactful near the beginning, when they realize that this person is dying. That's the time when it might most impact them, and they might feel and struggle emotionally with the knowledge now that they're losing the person they love. So, that this grief, the pain of the grief might occur quite early, and commonly will not occur much towards the end as you've adapted to the situation. So you don't necessarily have so-called normal grief when the person dies. And that is then, of course, not because you didn't care for them, it's because you learned to adapt and deal with it over the previous months and years. Next slide. So as somebody gets dementia, then they lose memory of things, including what they've learned from the Bible, including all that they have learned about the Lord and salvation. And roughly speaking, you lose the most complex things and the most things you've most recently learned earliest, and you hold on to those more basic things. But of course, we're not saved. Well, we are saved by our faith, but ultimately it's by God's grace. And it's an interesting thing, I think. I've never read anything on how Arminians deal with this theologically. But if it were true, that I have to continue to know, to trust in the Lord by my own understanding of my sinfulness and my own conviction and my own faith, then that seems to me to mean that once people reach advanced dementia, they lose salvation, because they're no longer capable of expressing such faith. They no longer have that knowledge of the Lord that leads to salvation. But of course, we know that isn't the case. We know it's ultimately the Lord's grace who has regenerated us. And the fact that I can no longer, with my severe dementia, confess faith in Christ, the fact that, if you ask me, are you going to go to heaven? I can't even understand what the word heaven means. Doesn't mean I'm not going to go to heaven, because I go to heaven because of Christ's death for me and his resurrection for me, and the faith the Spirit gave me in him and the relationship that's brought me to him, not because of what I do. It's by grace we've been saved, and therefore, people with dementia lose awareness of salvation, and that can be very difficult. But it's also fragmentary, so people will remember certain things, remember certain verses from the Bible, remember certain truths, remember certain hymns, and so on. And, you can find those things, lock onto those things, and encourage them, and engage with them with those things. So, there are things that people do remember, can encourage, even when they don't understand anymore. So the fact that somebody is unable to express that relationship, obviously they still have a relationship with the Lord. The relationship with the Lord is not lost because it's from the Lord as well, and at some level I think they continue to experience that, and my biblical justification is John the Baptist in the womb, who even at that age when he wouldn't seem to have had the mental function to, as it were, engage with the Lord, nonetheless has a relationship. Because a relationship isn't ultimately dependent on my cognitive function. And a relationship that you have with a person with dementia, it's two-way, isn't it? So the person with dementia now is unable to express their relationship with you. They're unable to express their relationship with the Lord. But from your side, you can still love them. You still relate to them. You can still speak and encourage them and seek out ways then to support them and to get through to them. And people pick up body language even when higher mental function is very lost. So the fact that somebody can't answer questions, and answer the catechism and all of that, doesn't mean that they don't relate to you. And it's one of the things you need to say to people, and you learn to tell people who are caring for those with dementia is, he might not understand what you're saying, but he can feel or sense, he knows how you're reacting. So if you were being rude and dismissive and talking in front of him, he knows that at some level that's kind of beyond language, that's to do with the way we relate fundamentally. Just like babies pick up things, people can pick up things. It's not necessarily, you don't have to have the cognitive ability to express and explain. You pick that up. And so it's very important then when you're engaging with somebody with dementia to keep giving the input from your side, even when you don't feel you're getting anything back from their side. And that's how God deals with us. He keeps giving to us even when we don't give back as we ought to do, and sometimes don't at all as we should from our side. So relationships, ought to be two-way. There ought to be engagement on both sides. With dementia, at some point they might not be able to be like that, but you can still relate and support somebody. Next slide. So there are certain things that people don't talk about with dementia, okay? Particularly with its dementia and Christian people, okay? So they don't say that he wanders around and he swears at me. Because he's been, an elder in the church for 30 years, and he never swore. But he is now. I don't say he hits me. He's always pursuing me, shadowing me around the house and hitting me. It doesn't matter what I try and do, he's aggressive to me. He follows me around and he molests me sexually. And you might be the daughter, not the wife. The daughter is trying to care for your father, and he gropes you. And people don't, of course, say that because it's so difficult to say. And I'm not saying that they ought to be saying that, but I am saying that you, if you're trying to help people with dementia, and especially the family members who are suffering like this, be aware of it. And just as I was saying, I'm asking about suicidal thinking. Let's seek an opportunity to kind of ask about some of these things that might be going on. Because otherwise the person is completely isolated because they can't tell anybody about these kinds of things, which are horrendous for them to experience. So it's not again because having asked you're going to give an answer. It is because having asked you can then show that you are sympathizing and supporting them. There isn't, a magic answer that will make these things go away. Certainly not one that you can provide. I can provide certain treatments to modify some of these things, try and help with that. But fundamentally, from your point of view, it's supporting the person who's supporting the person with dementia by being aware and being willing to talk about in private, in an appropriate situation, some of these extremely difficult issues. Next slide. Okay, so somebody asked before about personal responsibility. So of course I've left this till I've only got 1 minute left. So personal responsibility. So Andrew Sims was a Christian psychiatrist present to the Royal College some years ago. So he said, in trying to decide what is and what is not mental illness, it's useful to consider different dimensions. For example, contrasting the mentally ill and the mentally healthy. So that's what I was doing before. What do we mean by mental illness? How do we distinguish that between mental health? But an entirely separate and independent dimension is good, bad, and right and wrong. We don't define mental illness in terms of moral behavior, which goes to one of the questions that was raised earlier. This is a different construct or a different concept. That these variables are independent of each other is obvious, but it does need stating. Okay, next slide. So mental capacity then, that is how much one understands about what's going on, and therefore how much can they take responsibility for what they do in the world. Okay, so mental capacity, we're talking about the mental ability, the capacity to understand and take responsible decisions for our actions and all our behavior. Okay, so if you just go to the next slide and we'll come back again, I think. I never know which way around to do this. So mental capacity is not binary. That is, it's not you either have it or you don't. Often people speak like that and they say, does he have capacity or not? And that's a wrong question. It's does he or she have capacity for this decision? And decisions vary in how easy or difficult they are to make. And one of the things, so the hardest decisions are on the left side here. And of course, being a consultant, I think one of the hardest things is to make decisions as a consultant. But, there are certain decisions that involve digesting, taking in and balancing up lots of different pieces of information, lots of different conflicting pressures and so on. And you've got to weigh all that up, being a chief executive. There are sorts of responsible decisions, very high level. And you don't have to have much of a mental illness to be able to not make those kinds of decisions. Okay, at the far end, or towards the far end, we'll come back to moral, it's kind of marriage. It's well recognized that marriage, in terms of capacity, is an easy decision. Okay. Now, I mentioned marriage to make the point that it isn't, whether a decision is easy or difficult, is nothing to do with the importance of the decision. Okay, I think we'd all recognize that deciding whether to marry someone or not is an important decision, but that doesn't make it a difficult decision mentally. Why? Because, from the time we grow up learning about what marriage is from when we're children. So all our lives we learn, we know what marriage is. Okay? So we have to then lose a lot of mental function to no longer be able to understand what marriage is. Okay? That's why marriage, although it's an important decision, is an easy one to make, because we all have a good grasp of what it is. So if you think about taking an antidepressant, I've got, a medication I've got towards the easier end compared with having surgery, okay? Because most of us understand, I could take an antidepressant, I could take a drug, the doctor says take it for this condition, and that's not a difficult decision to take, okay? But it's much more difficult to understand, some kind of surgical procedure, because you've got to know a bit more about what it means, what exactly is a surgeon going to do to me in cutting me open and so on. So that's a more difficult decision to make than taking a drug. So in terms of dementia, understanding where you want to live, who you want to look after you is an easier decision than taking these medical decisions about treatment. So it's sort of trying towards this end. In terms of, so I've put there, where is it? Oh, it's disappeared. I had LPAs on there. So making a will and then a lasting power of attorney, they're in the kind of middle area, okay? So making a will is a bit easier because most of us grow up, we know the idea of making a will, it's leaving, my possessions to people I want to have them. A lasting power of attorney requires more mental function because we don't grow up learning about lasting powers of attorney. But it's not that difficult because it means that I'm asking this person to take care of my finances while I'm alive. Or I'm asking them to make decisions about my care while I'm alive. It's not that difficult, but it's more difficult than making a will. Okay, so the principle is different levels of complexity, not binary. It's not a yes, no, has or doesn't have capacity. And if in the Mental Capacity Act, we all, under the Mental Capacity Act, are able to make decisions about somebody's capacity. Okay, you don't have to be a consultant psychiatrist, you don't have to be a doctor or a nurse. Everybody is making decisions about the capacity of people to make decisions in their lives. Family members make these decisions, okay? Now, if you just go back a slide again. So moral decisions then, remember I put moral at the farthest end, okay? Because moral decisions are very easy. In the same sort of way as we grow up learning about what marriage is, everybody grows up being told what's right and wrong. That you don't swear at people, you don't hit people, you don't steal things from people and so on. Everybody is taught about these things from their earliest years. And therefore, you have to lose a lot of mental function to no longer be able to understand the difference between these, what's right and wrong in these sorts of things. Okay? But more than that, of course, we know that the Lord, as having made us in his image, has put his law within us. That written on the hearts as image bearers is the law of God, telling us what's right and wrong. That is how God is, what he says is right and wrong. So as image bearers, every human being knows these things. We're all brought up being taught these things. Yes, they don't exactly correspond from people out there to what the Lord says is right and wrong, but the principle that you know what's right and wrong is there, it's written in us, it's taught to us, it's drilled into us. So it takes a lot of loss of capacity to remove the ability to make a decision about right and wrong. Okay? So people with mental illness, the great majority of people with mental illnesses are able to make moral decisions. People with mental illnesses, by and large, are responsible for their actions. They're not absolved from sin because they've got depression or schizophrenia or something. They're responsible. Now, when those illnesses become very, very severe, and with dementia, when dementia's severe, then they no longer know those things, what's right and wrong. So it's possible for people with mental illnesses to lose capacity to know what's right and wrong. So this man then who's following his wife around and groping her, okay, doesn't understand what he's doing. He's lost all sense of what this means, okay? He's not responsible for his actions. And therefore I'd say he's not sinning in doing this, okay? He is no longer having capacity because of that. On the other hand, people earlier in their illness, dementia or otherwise, do know what they're doing. They are responsible and need to be held responsible for those decisions about right and wrong. And as I say, most people, my now quite extensive experience, most people with mental illnesses are responsible. That includes most people with dementia. But with severe psychosis, severe depression, and especially dementia, people reach a stage where their mental function is not good enough to enable them to understand right and wrong, and therefore be held accountable for their actions. Okay? And then finally, I think this is finally, so a good Catch-22. Now, Catch-22 is not a book I would recommend by any means. Catch-22, I read it many years ago before I was a Christian, and it's a book about being a pilot, pilots in the Second World War, flying in missions into Italy in the Second World War, and the book's about the horrors of war. It's an anti-war book, and it's about the fact that people didn't want to take on these missions because the mortality rate was so high. And so the joke, the catch-22 in the book is that the exemption from being able to fly as an American pilot into Italy was that you were insane. Okay, if you were insane, you were exempt from flying. You had to go to the doctor and get signed, as insane. So the guy goes to the doctor and says, I can't fly, doctor, I'm insane. And the guy says, well, why don't you want to, well, I don't want to fly. And he says, well, you have to fly. Only insane people want to fly. So he says, wow, that's a catch, isn't it? Yeah, catch-22, the best there is. Now, it's used generally about things where you can't get out of a situation. So a good catch-22 is, you see, that if somebody says to you, I'm mentally ill, it's not my fault I did that. That means they are responsible. Because if you've got the mental function that's good enough to be able to think like that, that means that you are responsible for your actions. You never get anybody with a severe dementia who says, I didn't mean to hurt them when I hit them. It's not my fault, it's my dementia. Of course you don't, because you need a good level of capacity and mental function, therefore, to be able to claim that you don't have responsibility. So if anybody ever says to you, in my opinion, it's because I'm depressed that I did it, or it's not my fault because I was depressed or anxious, you say, well, it is your fault, and it is your fault because of what I call this good catch-22. If you're aware that you are trying to claim that you're not responsible, then you are responsible, okay? The only people who are not responsible are those who are so impaired that they will never claim that they're not responsible for their actions. If you see people with severe dementia, you see people with severe psychosis, they're completely incapable of making those kinds of claims. They're too damaged by their illness to seek exemption in that way, as it were, from their moral responsibility.